Hi, welcome to Necrotic Noise. We're your hosts, Nina.
Becca.
And Jasmine.
Today we'll be exploring the diagnostic power of clinical exercise testing. We're going to be discussing the symptoms like angina, shortness of breath, leg pain, and as they act as clues for cardiopulmonary issues, and how exercise tests can help identify the coronary artery diseases before they become clinically evident. We'll also delve into the role of exercise testing in post-heart attack care and before heart procedures, considering factors like age and gender that affect diagnostic accuracy. So let's dive in.
Also, in this episode, we'll uncover how exercise testing guides our personalized rehab plans. And we're going to learn how clinicians use test results to design specialized exercise routines for specific individuals' needs that ensures an effective recovery in their rehab plan. And we'll also discuss how these tests help assess readiness for physically demanding jobs and just physical functioning overall, and making sure that you're safe to return to work.
All right, so tune in as we explore clinical role of exercise testing for emergencies and surgical preparation. We will discover how these tests serve a cost-efficient tool that will rule out heart attacks in the ER, or providing appropriate risk assessments, especially for patients that have heart issues. We would also explore factors affecting test accuracy, providing valuable insights as well for healthcare professionals and patients alike.
So, what is clinical exercise testing? Why is it important? Why do we care? In the simplest terms, clinical exercise testing involves the evaluation of new treatments or procedures on human subjects to determine their safety, efficacy, and potential side effects. One of the biggest benefits of exercise testing is using the results we get from the graded exercise tests in order to customize treatments and exercise prescriptions unique to every single individual and their needs.
That's a great benefit, Jasmine. I also think another benefit would be that it helps determine the baseline of that patient's health status and the nature that the clinician would follow to help them with any follow-up therapy or interventions that would help them with their recovery.
100%, Nina. I love that you brought that up. Now, let's hear a little bit more from you and Becca about the clinical inclusion criteria for graded exercise testing.
So inclusion criteria is very vital for ensuring the right patient are selected for specific tests or treatments. For graded exercise testing, we consider factors important as age, medical history, or current health status to determine this eligibility. Starting off with the most common one, we're going to look for signs and symptoms such as IHD, which is ischemic heart disease, which is a heart problem caused by narrow heart arteries. These symptoms can include chest pain, shortness of breath, or even heart palpitations. This could also be used for general measurement of exercise capacity. This is to measure someone's body's ability to perform and sustain physical activity. We want to also aim for cardiac diagnosis, which can be a person presenting an emergency with acute or chronic syndrome, or people with resolved symptoms. We also want to aim for pulmonary diseases like COPD, which is chronic obstructive pulmonary disease. It's a group of diseases that cause airflow blockages and or related breathing problems.
Right, and then some more inclusionary criteria includes assessment of exercise intolerance, unexplained shortness of breath, exercise-induced bronchoconstriction, some more pulmonary diseases, exercise-induced arrhythmias, and pacemaker and heart rate responses to exercise. Also, especially clinicians need to know about, beta blockers and ACE inhibitors, and how the heart responds to those to regular exercise and exercise testing. We're looking at also preoperative risk evaluations. So before a patient goes into some surgery, claudication as that's presented like in peripheral artery disease, disability evaluations, and also it's used in physical activity counseling. Some more include used to treat, or I'm sorry, used to predict prognosis. So if we remember our inverse relationship of cardiorespiratory fitness and mortality rate, which is the death rate, we know that higher the CRF, our risk of CBD mortality decreases significantly. And then we're also using those criteria to assess our return to work, especially if a patient has had a recent cardiac event or even not so recent cardiac event, and helps us develop exercise prescription for those known heart diseases. So all these establishing all these criteria, it ensures that the participants are suitable for the exercise trial, and so that we can get those meaningful results back. So we're going to move on to selecting the treadmill protocols for the graded exercise testing. The selection that a clinician would typically use depends on the patient's physical activity history, their medical history, and also their symptomology.
Right. So in the clinical world, there's a number of graded exercise tests that we can perform. However, the Bruce protocol stands out as the most employed treadmill procedure because it is the gold standard for conducting graded exercise tests in clinical settings. So the procedure involves gradually escalating levels of speed and incline every 3 minutes, beginning at stage 1. So in stage 1, participants are just walking at a light 1.7 mile pace with a 10% incline grade. And as they keep going with the test, they're going to be it's going to be introducing higher speeds and higher inclines. So the further that the patient goes into the stages, the more aerobic endurance that they have, and the less likely they are to have any cardiac problems or
So it's very crucial that we monitor certain variables like heart rate, blood pressure, of course, the EKG machine, outward signs and symptoms, and the rate perceived exertion scale from the patient, or RPE for short. Most of these variables are typically measured in both supine and standing positions before the test begins. During the test, however, heart rate, blood pressure, RPE are measured every 2 minutes. Signs and symptoms are monitored constantly throughout the test, even after. These variables are again measured immediately post-exercise and again at 60 seconds. Only EKG and blood pressure are measured again 2 minutes post-test exercise to ensure the patient to ensure the patient's safety and allow them to time to return back to their baseline.
So when we're explaining these graded exercise testings to the patient, it's essential to discuss the purpose of these tests, how they're going to be conducted, and if there's any potential risks involved. So the clinician ensures the patient is properly informed, what to expect about the test, explicit consent to the test, and know how to prepare for it as far as hydration, rest, and diet. That's really important. So open communication with the patient is key to ensure that their comfortability and they understand the entire testing process before the testing begins. So informed consent, as we all know, it really ensures that the patient fully understands the nature of the procedure, its potential risks and benefits, if there's any alternative options, and the right to refuse or withdraw they have the right to refuse or withdraw consent at any time. A healthcare provider has to provide all that relevant information in a clear, understandable document, address any questions or concerns that the patient might have, and obtain a voluntary agreement to proceed with that test. So I know that you also mentioned in class, CYA, cover your ass. That's part of informed consent as well. And it protects us as the clinicians, and it protects the patients from any type of negligence on the clinician's part as well. So there are other signs and symptoms that there are also the signs and symptoms that the clinician has to look out for when conducting the graded exercise tests. And knowing the endpoints and the indications to terminate that test is really essential to the what the clinicians do.
Right. And of those signs and symptoms, there's going to be 8 main ones. One is going to be severe chest pain or discomfort. Another is going to be significant shortness of breath or wheezing, dizziness or lightheadedness, excessive fatigue or weakness, any abnormal changes in the heart rate or any like arrhythmias. A sudden drop in blood pressure would also be a sign or symptom that we need to look out for when they're doing the graded exercise test, as well as any signs of potential MIs, which we'll be able to see on the EKG with any ST segment depression on the ECG. And for number 8, we're also going to be looking for any unusual or alarming symptoms reported by the patient. Ultimately, the patient knows how much workload they can perform and what they can take, what their body can take. So it's very, very important that we let the patient also feel comfortable in letting us know when they're done, instead of just pushing themselves for like the sake of like a PR, or just for the sake of their own safety, honestly. And now a word from our sponsors.
All morning.
Hello?
Hello, this is Life Alert. Your mother had an emergency, and we dispatched paramedics to her home.
Oh my gosh. Okay, what happened?
She had a fall, but don't worry. She is safe, and the paramedics are helping her right now.
Thank you.
Is Grandma okay?
She's gonna be okay. Life Alert send help.
Life Alert saves a life every 11 minutes. With one
All right, thanks, Life Alert. Now let's jump back in. Moving forward, we'll be going over the contradictions for graded exercise testing. This includes absolute and relative factors that may affect the safety or the efficiency of the test. Jazz, would you mind walking us through the absolute contradictions for the clinical testing, please?
Of course. Absolute contraindications are going to be those where conducting exercise testing would actually pose significant risk to the patient's health. So you can think of absolute contraindications like big red stop signs. So if you see one, you don't proceed under any circumstances. So an example I like to think of is if someone is allergic to a medication, using that medication would be an absolute contraindication. So essentially, for something to be considered an absolute contraindications, the risk would outweigh the benefits.
So some absolute contraindications would include an acute myocardial infarction within the last 2 days, ongoing unstable angina. That's something that's not, it's not treated with any medication. Uncontrolled cardiac arrhythmias with a hemodynamic compromise, active endocarditis. We have a symptomatic severe aortic stenosis, and decompensated heart failure is some absolute contraindications.
Also, don't forget about acute pulmonary embolisms, pulmonary infarctions, or deep venous thrombosis, as well as acute myocarditis or pericarditis, as well as acute aortic dissections, and basically any physical disability that precludes safe and adequate testing. Nina, could you elaborate on some of these relative contraindications?
Of course. So, relative contraindications are like yellow caution signs, right? You slow down, you evaluate the situation, and you proceed with caution as necessary. So, with relative contraindications, benefits would outweigh those risks. So, for this type of population, so we would want them getting that exercise every day and trying to get their health back in on track. So, for example, using a medication that might have side effects on somebody with a history of heart problems might be a relative contraindication, and it's the clinician's duty or job to know how that medication affects them during exercise and adjusting any type of program to accommodate that. So some of those conditions include known obstructive left main coronary artery stenosis, which is a mouthful, and some moderate to severe aortic stenosis with an uncertain relationship to symptoms would be another one.
All right, continuing off of you, Nina, some common other contradictions include tachyarrhythmias with uncontrolled ventricular rates, acquired advanced or complete heart block, recent stroke or an ischemic attack, mental impairment with a limited availability to cooperate, resting hypertension, which would have systolic over 200 and diastolic over 110, and uncorrected medical conditions such as significant anemia is very important to electrolyte imbalances and hyperthyroidism as well.
So overall, identifying and understanding these contraindications is extremely essential for ensuring the overall safety of our patients during the testing process. So it's really important that clinicians are aware of these protocols, procedures, and contraindications to ensure patient safety above all else. That's a wrap for today's episode. Thank you, Nina and Becca, for joining us today. You're listening to Necrotic Noise. Thanks for tuning in.
Bye.